Record button. There we go. Great. So great to have you all here. And this afternoon, I think we especially excited to welcome the team from WITS under the leadership of Dr. Venita Philip, senior clinical hematologist, very experienced examiner, as well as leader of the team up there at the moment, and who's been taking over the reins from Professor Musa Patel. So Venita, a big welcome to you as co-chairperson of this afternoon, and thank you very much for organizing this afternoon session with your team. So I'll be handing over to her in a minute, but before I do that, just a few housekeeping rules. So around the top of the hour, a link will be posted in the chat box, which will allow you to click on and register for CPD points. So do not put in your MP number, etc. in the chat box. You can do that on the registration link. So that will be somewhere towards the later in the presentation or presentations. Then, because not everyone is always here right at the end, I want to just today in advance say a big thank you to all of those who make this weekly session possible. In particular, Prof. Stelverberg, who organizes with Dr. Gerdien Kritzinger the speakers, makes the arrangements, the logistics, sends out the invites, and quite a bit of organization behind the screens. Thank you so much to both of you, to Melanie Davids, who organizes the CPD points on request. Please note, on request. You can get your CPD certificates from her if you just email her. And also a big thank you to all our divisional heads and their teams for taking part so enthusiastically. And also from time to time, we do have pharmaceutical companies that sponsor a speaker, and we will thank them as the time comes. When that happens, we will mention that specifically. So today is an important topic, and one that we do see quite frequently, especially in the age of HIV and AIDS, but I won't give anything away. I'm going to hand over directly to my co-chair, Dr. Venita Philip from the University of the Witwatersrand. Welcome and thank you, Venita.
Thank you very much, Vernon, for your kind introduction. I know it's Valentine's Day, and I'm sorry that we have to keep you all here in front of a screen, but I'd like to ask Drs. Alimia and Gokwana to please start their presentation. They're both fellows in the clinical hematology unit, and will be presenting topic on a not a red cell insight. Thank you. You can go ahead.
I must say, Dr. Philip, you did very well with pronouncing my surname this time. Thank you. Good afternoon, everybody. I am Dr. Lindobuhle Gokwana. I'm with my colleague, Dr. Esi Alimia, Shiny Alimia. We are both, as Dr. Philip says, specialist physicians and clinical hematology fellows at Chris Hani Baragwanath Hospital. And today we will be presenting to you about pure red cell aplasia. I'm going to hand over to Shiny, where she's going to present the first case.
Okay, so good afternoon, everyone. Thank you for joining. Let's begin. So I'm going to be discussing the first case presentation. Okay, so the first case presentation is of a 33-year-old gentleman, married, living in Soweto, working in retail and sales. He presented to us at Chris Hani Baragwanath for the first time in June of 2019 with a symptomatic anemia, of which he had a 4-day history. He was complaining of weakness and fatigue with associated exertional dyspnea and lower back pain. He reports that he was diagnosed a few years prior, end of 2015, 2016, with what he termed as pure red cell aplasia at Tembisa Hospital. He then reports that he had subsequently received 3 courses of intravenous immunoglobulin already, each course consisting of 5 days, and that his last dose he received in November of 2018. He also disclosed that he required multiple blood transfusions for repeated episodes of symptomatic anemia. On his past medical history, he was diagnosed with retroviral disease in 2016, for which he started on antiretroviral therapy at Germiston, and it comprised of the fixed drug combination of tenofovir, emtricitabine, and efavirenz. He reported no previous opportunistic infections or no previous infections with tuberculosis, and no other background comorbidities were noted. He reported sober habits and no other drug history, both over the counter and through other doctors or potential hospitals, and no past surgical history or family history. On clinical examination, he was hemodynamically stable. He had a slight tachycardia of 102 beats per minute. He was apyrexial. General examination, the most marked finding or feature was that there was evidence of subconjunctival pallor. There was no lymphadenopathy, no jaundice, no pedal edema, nothing to suggest he was in a fluid overload state or in heart failure, no skin changes. On cardiovascular examination, he had normal heart sounds, no added sounds, no murmurs. No chest examination was clear. On abdominal examination, there was no evidence of any organomegaly, no masses, and his neurological exam was pretty much unremarkable, normal. Okay. Then of note, on his investigations on his bloods, as we can see here, when he presented in June of 2019, there's evidence of a severe anemia, hemoglobin of 5.7, which is normochromic and normocytic with a normal MCV, MCHC, and a thrombocytosis. His differential count was unremarkable, but of note, he had a markedly reduced reticulocyte production index of 0.1. His renal function, calcium, magnesium phosphate, and liver function tests were relatively unremarkable. And a baseline CD4 count and viral load were done again with us. And good to say that his viral load was suppressed, lower than detectable, and he had a fairly decent CD4 count of 323. A full viral panel was done, including hepatitis screen, TPHA, RPR for syphilis, EBV, CMV, and a baseline ANA was done, and all of which subsequently came back negative. A baseline iron studies was also done, as he openly disclosed that he had actually received multiple transfusions. He could not quantify how many. And on his iron studies, it shows that he's got a markedly elevated iron saturation with a ferritin of almost over 3,200. Serum folate was reduced and a B12 was preserved. Unfortunately, the bone marrow aspirate and trephine that was done, aspirate was hemodilute and relatively aparticulate with very limited paucicellular trails. And the trephine, unfortunately, was inadequate as well. Despite that, they could see scant pronomoblasts, and there was marked erythroid maturation arrest with erythroid hypoplasia. And parvovirus B19 PCR was sent off on both the bone marrow aspirate and peripheral blood, and it had come back as positive. Okay. So subsequently, in the course of his management, it was both supportive and specific. Supportively, we gave blood products, and specifically, we opted to give him initially cyclosporin and prednisone for the immunosuppressants, and then we brought on IV immunoglobulin as the course went on. We did a baseline audiology screen prior to starting his iron chelators, put him on some iron chelators in the form of desferrioxamine, reiterated the importance of ARV compliance from the get-go and on subsequent visits, and screened for and stopped any potential causative drugs, which I'm going to go on his timeline. So how he progressed: he had presented to us around June. Subsequently, we saw him repeatedly in our outpatient setting, and he also had a few admissions. So around August 2019, his hemoglobin hovered around 6.9. As you can see, throughout the course of 2019 to mid-2020, anywhere between 6.5, 5.2, 7.1. we actually decided to give him another course of intravenous immunoglobulin in 2019. And subsequent to that, his hemoglobin actually rose up to 9.6, but went back down again. We checked his CD4 and viral load again. Viral load was suppressed. He was taking his ARVs, and parvovirus PCR remained positive in November. Despite his hemoglobin coming up after that initial course of IV immunoglobulin, it went back down again down to 7.1. So in February of 2020, we opted for another course of IV immunoglobulins. And there was actually not much of a response, unlike that initial time, end of September. So then the decision was made that we would also put him onto additional immunosuppressants in the form of oral MMF tablets. So he progressed with pretty much the same hemoglobin course, never actually even reached above hemoglobin of more than 7. Then some investigative work was fortunately done at our OPD setting, and we remembered that he was actually on emtricitabine as part of his fixed drug combination. So our infectious diseases colleagues were brought on board, and they opted to change the emtricitabine lamivudine out and put him onto abacavir and maintained with the tenofovir and the efavirenz. That happened around September of 2020. There was a note of his hemoglobin going up from 4 to 8. But then subsequent to that, it went back down again, as we see around January. It hovered at 7.9, went down to 6.2. We checked his viral load again, was suppressed. His parvo PCR remained positive on peripheral blood. So in July, we opted again for another dose of intravenous immunoglobulin. And there was a response. His HB actually stayed and hovered.
Sorry, can I just check? Is the sound lost only on my side or everywhere?
I think it's everywhere.
Okay, it sounded like someone came back online a moment ago.
Oh, can you hear me now, Prof?
Yes, we can.
Okay.
Maybe you can just
Sorry,
start again from you repeated the polygram for the IVIG.
Oh, okay. All right, sure. Okay. So we actually then decided, so the ARV change happened around September of 2020 when his HB had gone down all the way to 4. And the emtricitabine lamivudine was changed out with the help of infectious diseases to abacavir, and the tenofovir and the efavirenz was maintained. There was a slight improvement in his hemoglobin up to 8, but then it went back down again and deteriorated to 6. His viral load was checked again, and he had claimed compliance, and parvovirus PCR was repeated around July, which remained positive. So we took the decision to give him a repeated course of intravenous immunoglobulin in July, and there was a response to his hemoglobin. It came up to 13. He actually remained transfusion-free for 5 months. And unfortunately, on his most recent last visit in January of this year, his HB shot back down again because he has defaulted his ARVs. And as you can subsequently see now, his viral load is 108,000 copies, and it was always LDL. So that is how it has progressed with him. Yes, so that's my case presentation. I'm going to hand over to Lyndall for case presentation 2, and then we'll see from there.
Okay, so my case is not nearly as interesting as yours, Shiny. So I will be presenting a 48-year-old gentleman who was from Sebokeng. He worked as a general worker in a can manufacturing company. He was previously well with no chronic illnesses known to him, and he presented to the base hospital with fatigue, pallor, and dyspnea. He was noted to have a severe normocytic anemia and had recurrent admissions for workup where they did upper endoscopy, lower endoscopy, and multiple bone marrow aspirates and trephines. He had no other complaints on systemic inquiry. On Can you hear me? Hello?
Yes, we can hear you well.
Okay. On clinical examination, his vitals were within normal limits. His general examination was unremarkable, except for severe or marked subconjunctival pallor. His cardiovascular system was normal. His respiratory system was within normal limits. His abdominal examination was also normal, and his neurological examination was also normal. But it's of note that he had no fatigability, no diplopia, and no long tract signs that were noted. A chest X-ray was done as routine and was found to have an anterior mediastinal mass, which was thought to be a thymoma. You can see it there, and no lung parenchymal lesions were noted or associated with it. His hemoglobin, I was able to trace back to 2013 when he presented to his local clinic, and his hemoglobin at that time was 15.3. Then subsequently in 2016, at his first presentation with the fatigue, the pallor, and the weakness, he had a hemoglobin of 4.2. Of note, it was normocytic, but his white cell count and his platelet counts were not involved, and they were within normal limits, but his reticulocyte production index was 0.1 at that time. In 2017, he presents again, but he presents post-transfusion with a hemoglobin of 8.4 to the base hospital, but this is macrocytic, but still normal white cell count and platelet count, with a reticulocyte production index of 0.1. In 2018, he was referred to Baragwanath Hospital with a hemoglobin of 5.6, which was normocytic. His white cell count was 9.77, and his platelet count was 529. He had a reticulocyte production index at that time of 0.1. It was 0. We then proceeded to investigate him, where his parvovirus PCR was negative. He was negative for Epstein-Barr virus. Hepatitis A, B, and C were all negative. His HIV was negative. His immunoglobulins were within normal limits, but his Coombs was positive, though there was no features of hemolytic anemia. His iron at the time was 24 with a ferritin of 611, and his iron saturation was 65%. I must note that we were not given transfusion history prior to his referral, so we don't know how much he had been transfused prior to this. His autoimmune workup, rheumatoid factor, was normal with an ANA that was negative. And of note, especially in the history of thymoma, is that his acetylcholine receptor antibody was positive, but he had no features of myasthenia gravis on examination. His bone marrow aspirate was, 2 bone marrow aspirates were done at the base hospital, and they were non-diagnostic. They were aparticulate and hemodilute. Unfortunately, the one done at Baragwanath also was aparticulate and hemodilute, so no further comment could be made. But the trephine biopsy was of adequate quality. And what you can note here is that it was moderately hypocellular to normocellular for his age at 48. There were areas that were more hypocellular than the rest. And on higher power, we can appreciate that you can't see or can't appreciate any red cell precursors. On a higher power, we did note, though, just about 2 pronormoblasts, but nothing else. His CT scan showed an anterior mediastinal mass that was encapsulated, typical of a thymoma. And we proceeded to manage him by giving him 30 milligrams of prednisone daily. An ultrasound-guided biopsy of the mediastinal mass was performed. Subsequent thymectomy was done by the cardiothoracic team at Charlotte Maxeke. And after thymectomy, he was then started on cyclosporin. He achieved remission with immunosuppressants and thymectomy. The thymic resection was 250 grams, and it had a length of 16.5 centimeters by 7 by 35, and there were no surgical complications post-thymectomy. So this is just a sequence of events of how our patient fared out. So he was started on prednisone in July 2018. Transfusion history, as I mentioned, prior to that was uncertain. He then had a ultrasound-guided biopsy to confirm the presence of a thymoma. He then had a thymectomy in August 2018. On return from Charlotte Maxeke, his hemoglobin was 7.3. He was started on cyclosporin at this time and given a unit of packed red cells. A month later, his hemoglobin was 7.2, but he also had a purulent ear discharge, possibly a complication of the immunosuppressive therapy we were giving. He was then referred to ENT, and he was given a unit of packed red cells. On repeat, when he came back, he was noted to have a hemoglobin of 12. A prednisone taper was started. Then his next review 2 months later, he had a hemoglobin of 15.2, where a cyclosporin taper was started. His last presentation to us was in November 2020, where he had a hemoglobin of 16.3 of all agents. But unfortunately, he was supposed to come back for review on the 17th of May 2021, and he defaulted follow-up. I'm going to hand over to Shiny again, where she's going to speak a little bit about pure red cell aplasia.
Okay, all right. So short little introduction. So pure red cell aplasia, it's a diverse group of disorders characterized by severe progressive normochromic, normocytic anemia with a reticulocytopenia. So as we saw in the 2 cases that my colleague and I presented, both cases severe anemia, both instances were normochromic, normocytic with a reticulocytopenia. There's also a lack of red cell precursors or arrest and differentiation of red cell progenitors, typically at the pro-erythroblast stage, and it can be from a variety of etiologies, which I'm going to elaborate on subsequently. So pure red cell aplasia can be divided into congenital and acquired. Under acquired, it can be primary or secondary, and in some instances, they also use acute versus chronic. Okay. So classification of pure red cell aplasias, the most common one under congenital is the Diamond-Blackfan anemia, and under acquired can be both primary or secondary. Under primary is the idiopathic, and it's autoimmune pure red cell aplasia, and in this category, we also include the transient erythroblastopenia of childhood. And then there's also the primary myelodysplastic pure red cell aplasia, very, very uncommon rare entity. And then under the secondary causes, common things happen commonly. So drugs being one of the most common causes, infections in our setting, and less commonly autoimmune collagen vascular disorders, lymphoproliferative disorders, can be associated with thymoma, other malignancies, both solid tumors and hematological, and other causes such as pregnancy and ABO mismatch in stem cell transplant. So in children, it's usually acute, self-limiting form, and that's the most common way of presenting, versus in adults tends to be more of a chronic form that's persistent, and it's usually secondary to an underlying disease. So this is actually some local data based on an MMed that was done by a fellow registrar at Chris Hani Baragwanath. And it was a retrospective MMed that looked at pure red cell patients, pure red cell aplasia patients at Chris Hani Baragwanath Academic Hospital over a 10-year period from 2008 to 2017. And it had a study population of 100 patients that we managed to find, they managed to find, of which 71 were female and 29 were male. The female to male ratio was actually about just under 2.5 to 1. The median age at presentation was roughly 34 years, with a range varying from 15 to 63 years. And the 3rd and the 4th decades was the most common age of presentation. The most common peripheral blood findings was anemia was evident in all patients. The mean hemoglobin was around 4.3 grams per deciliter, with a mean corpuscular volume of 85 and a mean RPI, reticulocyte production index, of 0.04. All the patients involved in this study had demonstrable secondary causes. Of the 100 patients, 97 were HIV seropositive, and of those 97, 43% had concomitant parvovirus B19 infection, and 32% had tuberculosis infection. And there was overlap seen with multiple underlying etiologies, such as parvovirus B19 with concomitant tuberculosis infection with an underlying lymphoproliferative disorder in the form of lymphoma, and plus minus in some instances also hepatitis B and C infection. Only 3% of the study population were HIV seronegative, and this underlying etiology was in pretty much all the cases attributable to an autoimmune disorder. So this is actually a lovely diagram that we stumbled across, Lynn and I, thankfully, on one of the latest ASH publications looking at the pathogenesis of pure red cell aplasia. And as is, there's variable mechanisms, can be drug-related, viruses in the form of parvovirus B19, or even immunodeficiency, and later, which my colleague will touch on, thymoma. And it can be a direct cytotoxic effect on the actual erythroid precursor, or it can be due to molecular mimicry, causing an indirect pathognomonic effect. So I just thought this was a very nice diagram to include. So touching on Diamond-Blackfan anemia, if you recall on the classification slide, it's the most common congenital cause, although very rare, and it results from mutations in genes coding for several ribosomal subunit proteins. The most common one being the RPS19, which is found in over 25% of cases. There are other genes that are included, all these ones mentioned here, but they're not as frequently as seen with the RPS19. The GATA1 mutation can also be seen in some cases. Diamond-Blackfan anemia classically presents in the first year of life. Therefore, unfortunately, my colleague and I, being adult clinical hematologists, I've yet to see one, neither has my colleague. Most commonly presents in plus minus 8 weeks of life. Its inheritance pattern is autosomal dominant. If associated with the GATA1 mutation, it's X-linked. There's usually an unremarkable family history with variable penetrance. Approximately 50% of patients with Diamond-Blackfan have physical abnormalities. There's evidence of short stature, cardiac defects, urogenital abnormalities. There can also be evidence of microcephaly with cleft palate, micrognathia, macroglossia, and deformed thumbs in the form of either absent or triphalangeal. Blood and bone marrow findings are very similar to pure red cell aplasia. In addition, there's also evidence of elevations in fetal hemoglobin, erythrocyte adenosine deaminase, and erythropoietin. Okay. Oh, I can't. Next one. Yeah. Sorry. Okay. Then there's also the transient erythroblastopenia of childhood, which would fall under the secondary causes, but a primary. And it's characterized by failure of red blood cell production in early childhood that remits spontaneously after about 1 to 2 months. It may present post-viral or transient to an autoimmune response. And it's crucial to distinguish from Diamond-Blackfan anemia, this transient erythroblastopenia of childhood. So this is a lovely table that actually distinguishes between the two, with transient erythroblastopenia of childhood in the first column and Diamond-Blackfan anemia in the second. So under family history, it's absent, usually not much, and possibly one under Diamond-Blackfan. Age of presentation in TEC is usually older than a year versus in Diamond-Blackfan, almost always younger than a year. Congenital abnormalities are possible in Diamond-Blackfan, as stated previously, whereas in TEC, it's usually absent. Then the MCV of note, it's usually normal in TEC, whereas it's increased. We commonly see a macrocytic anemia in Diamond-Blackfan, or that's been documented. And then fetal hemoglobin levels are usually normal in TEC, whereas it's increased in Diamond-Blackfan. And then the erythrocyte adenosine deaminase activity is typically normal versus increased in most cases of Diamond-Blackfan anemia. Then coming to drugs, over 50 drugs have been implicated with pure red cell aplasia. Usually the pure red cell aplasia resolves when the drug is stopped, can be due to the direct toxic effect rather than immune mediated. However, in some case reports, rifampicin has been associated with the IgG mediated inhibition of erythropoiesis. And the other drug that was controversial and found in a lot of our dialysis patients was the recombinant human erythropoietin, where pure red cell aplasia was seen, very rare complication, and in some instances developed anti-erythropoietin antibodies. Upon cessation of the drug, the aplasia persisted in quite a few cases. And as they researched or looked further into it, actually found that some of the rubber stoppers that were being used in the dialysis machines was actually the causative element. And when that was taken out, the aplasia actually resolved in a few of the cases. I'm not sure if this table is actually projecting properly. If not, I apologize, but it's a lovely table looking at quite a lot of the common drugs that have been implicated. It's from the Blood Journal article on pure red cell aplasia, where there's been multiple reports of it. And in some of the ones, like for instance, azathioprine mechanism still under investigation. So common ones are the antibiotics, anti-TB drugs, rifampicin, isoniazid, ARVs, lamivudine, zidovudine, anticonvulsants such as valproic acid, certain immunosuppressants, sulfasalazine, antibiotics in the form of Bactrim that we use quite commonly, trimethoprim, sulfamethoxazole. So then moving on to infections, parvovirus B19 being the most common one or documented one. It's usually transient and self-limited. It can cause a transient aplastic crisis in patients with chronic hemolytic anemias, and it can actually be chronic and persistent in immunocompromised patients, which is the setting in most of our patients in our case with concomitant HIV. Other infective causes, viral being HIV, cytomegalovirus, EBV, the hepatitises A, B, C, E, and mononucleosis as well. And then not as commonly bacterial, very, very rare group C strep, but not as rare the tuberculosis. So parvovirus B19 associated pure red cell aplasia. So parvovirus, it's a member of the Parvoviridae family, genus Erythrovirus. It's a small single-stranded non-enveloped DNA virus. And there's at least 4 different parvoviruses that have been documented to infect humans. Transmission is usually through respiratory droplets, can also occur vertically from infected mothers to fetuses, and also can occur in stem cell and organ transplant patients, and also in blood transfusion products. It directly infects the human erythroid progenitors through the red cell surface P antigen, globoside GB4. The P antigen receptors are present on erythroid precursors, megakaryocytes, and endothelial cells. It is common in childhood, with more than 50% having lifelong immunity. And it usually in childhood causes a self-limiting disease in healthy individuals, where you get a subclinical erythroid aplasia followed by a rash or arthralgia. The rash is typically a cheek rash. The maladistribution actually comes up as one of the differentials for, and then the entity erythema infectiosum. It's the most common form of parvovirus B19 infection. It's an acute disease of children, otherwise also known as fifth disease, and it's asymptomatic in 25 to 50% of cases, causing a non-specific prodromal illness. Sorry. Then there's the entity of transient aplastic crisis, where there's a precipitous drop in the hemoglobin and also marked erythroid hyperplasia in the marrow. And the at-risk groups for this transient aplastic crisis are usually, as stated before, chronic hemolytic disorders, so patients that suffer from concomitant hereditary spherocytosis or sickle cell disease, thalassemia, autoimmune hemolytic anemias, or any red cell enzyme deficiencies. Or if there's any evidence of concurrent erythroid stress, so patients that have recently suffered from hemorrhage or known with iron deficiency anemia, renal and stem cell transplant patients. And in patients with sickle cell disease, sometimes it can actually cause bone marrow necrosis, which can be fatal. Usually with the transient aplastic crisis, there's recovery in 1 week unless there's persistent infection. And persistent infection is usually in the setting of congenital immunodeficiencies, or most commonly in our case, immunosuppressed patients with concomitant HIV infection, or if there's underlying hematopoietic disorders, or if there happens to be a stem cell transplant recipient. They may develop the varying degrees of neutropenia and thrombocytopenia. Arthralgia and arthritis have been documented, but very rarely. It's a very, very rare cause of hemophagocytic syndrome. And moving on to idiopathic immune-mediated, there's a pathologic role of autoantibodies, natural killer cells, or T lymphocyte-mediated cells that cause a mediated attack on erythroid cells at various stages of development. Can be acute or transient or chronic, and in 10% of cases, it runs a very short self-limited course. Then myelodysplastic syndromes, they are very infrequent and rare causes. Then under autoimmune collagen vascular diseases like rheumatoid, lupus, scleroderma, dermatomyositis, polyarteritis nodosa, and under the group of lymphoproliferative disorders associated with pure red cell, could be chronic lymphocytic leukemia, the T-cell large granular lymphocytic leukemias, Hodgkin and non-Hodgkin, multiple myeloma, Waldenstrom's, macroglobulinemia, Castleman's diseases, and others, such as your myeloproliferative neoplasms and then acute lymphoblastic leukemias. And then also can be associated with ABO-incompatible stem cell transplant, and lastly, pregnancy. So for clinical features, very non-specific presentation. Most commonly, we'll see signs and symptoms of anemia. Other symptoms may be related to the underlying cause, possible infection, malignancy, or an autoimmune disease. Okay. I'm going to hand over to Lyndall, who's going to take us through diagnostics and the rest of the talk.
Thank you for that, Shani. So our diagnostic approach to pure red cell aplasia, as previously mentioned by Shani, that diagnosis should be expected in an isolated anemia if there's a reticulocytopenia and if there's any severe anemia that requires blood products that no cause is apparent, or no cause is apparent. The diagnostic criteria include normocytic and anormocytic normochromic anemia, a absolute reticulocyte count of less than 10,000, or a reticulocyte percentage of less than 0.5, a normal white cell count in the absence of an underlying lymphoproliferative, such as CLL, normal cellular bone marrow with erythroblasts accounting for less than 1%, or pro-erythroblasts with basophilic stippling accounting for less than 5% of all nucleated cells in the marrow. No significant abnormalities in myeloid, lymphocyte, and megakaryocytic lineages, except if the patient has any lymphoproliferative or myeloid malignancies. Laboratory investigations include a full blood count and peripheral blood smear, where, as I've mentioned, you note normocytic normochromic anemia. The anemia is often severe, and the blood smear is often unremarkable unless or except if it's concomitant with autoimmune hemolytic anemia. There's no change in white cell count or platelet count, except if there is concomitant lymphoproliferative disorders or myeloid disorders, as I mentioned earlier. The reticulocyte count is absent or markedly reduced, and the iron studies are often non-contributory, and the high iron and saturation levels may be seen, especially if the patient has undergone transfusion prior, but iron metabolism does not contribute to the pathogenesis of pure red cell aplasia. B12 and folate are investigations that I would do, particularly to exclude a nutritional cause for the anemia. The bone marrow morphology is an essential part of the diagnosis. The cellularity is often normal. The myeloid, lymphoid, and megakaryocytic maturations are also normal. There's absence of erythroid precursors, and as I mentioned before, the pronormoblasts with basophilic erythroblasts are present but account for less than 5%. Giant pronormoblasts with inclusion bodies or viral inclusions in cytoplasmic vacuoles can be seen in parvovirus B19, and it also assists in diagnosis of hematolymphoid neoplastic causes of pure red cell aplasia. These are just diagrams that I found from bone marrow pathology textbook, which shows the absence of red cell precursors. As you can appreciate granules, you can appreciate the lymphocytes, but no red cells. You can appreciate the giant pronormoblast with inclusions and some vacuoles in the cytoplasm. This is also another image showing a giant pronormoblast. This is Trefine images, the first of which showing red cell precursors, very scant. And this is an AGP stain showing how little there is of red cell precursors in the bone marrow. So how do we find a cause? So we need to go investigating. So first, for viral infections, we do viral PCRs, including parvovirus B19 PCR, hepatitis A, B, and C, and often E, and HIV ELISA and the CMV PCR. Bacterial infections, bacterial cultures and mycobacterial cultures could be of help. For solid tumors, imaging, tumor markers, tissue biopsy would be of help, which was the case with my patient. Autoimmune disorders, an ANA, a rheumatoid factor, an anti-CCP, and an ANCA could be of assistance, and also a thorough examination to exclude any features of autoimmune disease. Lymphoproliferative disorders, thorough examination once again, imaging, tissue biopsy, and bone marrow aspirates and trepines may be of assistance. Other hematological disorders can be evident on peripheral blood smear, bone marrow aspirate and trephine, and possible cytogenetic disorders. Drugs, a thorough drug history, as Shani showed you a nice table with a lot of drugs that were that could be causative in pure red cell aplasia. So a thorough drug history would help in diagnosis or finding a cause. And if you suspect any woman of childbearing age, a beta ACG needs to be done. And to exclude congenital causes, an erythrocyte ADA could be of help, HB electrophoresis, and genetic testing could be of assistance. Again, this is an image that I've adapted from the recent How I Manage by Ash that was published in October 2021 and on how I manage pure red cell aplasia. And similarly, as I've just mentioned to you, these are some of the investigations that would be of note or of assistance in working up a patient with pure red cell aplasia. The management of pure red cell aplasia, as with everything, there are supportive and specific measures. But first, before we start with supportive and specific, we need to observe to see if it spontaneously remits. As Shiny mentioned to you, that some pure red cell aplasias may spontaneously remit. But supportive measures include transfusions and management of transfusion-related complications. Specific measures include immunosuppression and sometimes surgical intervention, as was with my patient. Immune suppression includes prednisone and cyclosporin. These two are the two first-line agents in pure red cell aplasia, where prednisone can be given at 0.5 to 1 milligrams per kg. 40% of patients will respond to prednisone alone, but recent guidelines suggest dual therapy with cyclosporin. Cyclosporin A has a higher response rate than corticosteroids of about 75%. You give it at 6 milligrams per kilogram per day, and the concerns, as it is a calcineurin inhibitor, are nephrotoxicity, hepatotoxicity, and hypertension.
I think we've lost sound again. Linda Kuchle, can you hear me? If you can hear me, we've lost your sound. Okay, so let's just give her a minute. I think she's logging back in again.
I don't know what happened there. Sorry about that. I'll have to do this first before I share. I'm sorry, let's exit. No, I think it locked us out.
Oh, we logged out now.
No, we're on. We're back on. I'm just sharing screen. Right. Can you see my screen?
Yes, we
Can you
can,
go
thanks.
back to the previous page, please?
I just want to put it in presenter view. Sorry. Go back to the previous one.
Where did you lose sound of us, Prof? Dr. Philip?
Just when you were doing the drug levels for cyclosporine.
Okay,
Oh,
thank you. All right, so just to recap, immune suppression includes prednisone and cyclosporine, where prednisone we give at 0.5 to 1 milligrams per kilogram, and 40% of patients will respond to prednisone alone, but the recent guidelines suggest dual therapy with cyclosporine. Cyclosporine has a higher response rate than corticosteroids with about 75% response rate. We give it at a dose of 6 milligrams per kilogram per day, and the concerns are nephrotoxicity, hepatotoxicity, or hypertension. The drug levels must be monitored 3 to 5 days after initiation, and you should target a trough of 150 to 250 nanograms per ml. Other immune suppressants that can be used include cyclophosphamide, azathioprine, sirolimus, rituximab, IV immunoglobulin, alemtuzumab, and daclizumab, which is not available anymore. But I'll speak about these when we speak about refractory puerperal cell aplasia. Glucocorticoids, as it was mentioned last week, that maybe we should delve into more pharmacokinetics. The mechanism of action can be genomic and non-genomic effects, as we know, and it causes these cause the suppression of migration of neutrophils and reversal of capillary permeability. They have anti-tumor effects. They are lymphocidal. That's why we use them so well in ALL, and they have anti-emetic effects. Their pharmacokinetics, 50 to 90% of prednisone is absorbed and less than 50% is protein bound. The half-life is about 2 to 3 hours, and it's metabolized in the liver to prednisolone. This is just a schematic diagram that I found, which shows both the non-genomic and the genomic effects of glucocorticoids resulting in mRNA, and the effects that I've spoken about already. This is just a diagram showing the side effects of glucocorticoids and Cushing's, the effects of Cushing's syndrome, including weight gain, slow healing, moon phases, buffalo humps, weakness or myopathy, thinning and frigidity of the skin, excessive hairiness or hirsutism, stria, and we know about the psychosis or the depression or neurological effects of corticosteroids. This is also, I just found this to be nice, so I included it, where you have to strike a balance between the side effects and the therapeutic effects of glucocorticoids. Cyclosporin is a lipophilic 11 amino acid cyclic peptide. It's isolated from fungi. Its mechanism of action is by inhibiting calcineurin, which then inhibits the release of IL-2, TNF-alpha, IL-3, IL-4, GCSF, and interferon gamma. It thus inhibits cytokine-induced activation of T cells. It primarily acts on T helper cells and does not cause significant myelosuppression. It has two forms, modified and non-modified cyclosporin, and the modified has better absorption. It is lipophilic, thus it undergoes extensive body distribution, and its metabolism is via the cytochrome P450 CYP3A enzymes in the liver. A high-fat meal reduces its Cmax and reduces the area under the curve. So we need to warn our patients about this. And its half-life is about 8.4 hours, but it's prolonged in hepatic impairment. The side effects of cyclosporin include nephrotoxicity, which may manifest as acute increase in plasma creatinine, chronic progressive kidney disease, tubular dysfunction, or thrombotic microangiopathy. It can also cause hypertension, and the mechanisms in which it causes hypertension is renal vasoconstriction and sodium retention. It can they may present with neurotoxicity, including tremors, PRESS, and what we call the calcineurin inhibitor pain syndrome. They are predisposed to infections. There's a risk of malignancy, particularly squamous cell of the skin. Benign or malignant lymphoproliferative disorders are also included. There are some metabolic abnormalities that are noted with calcineurin inhibitors, particularly cyclosporin, including glucose intolerance, hyperlipidemia, hyperuricemia, hyperkalemia, and hypomagnesemia. Cyclosporin is contraindicated in concurrent malignancy, uncontrolled hypertension, and uncontrolled infections. Thymoma-associated pureate cell aplasia accounts for 7 to 10%. So pureate cell aplasia accounts for 7 to 10% of thymoma patients, but 5% of all pureate cell aplasia patients actually have thymoma. Other diseases that are associated with thymoma include myasthenia gravis. I mentioned earlier that my patient had acetylcholine receptor antibodies that were positive, but he never presented as a myasthenia gravis. Good's syndrome, which is an A gamma globulinemia, and his immunoglobulins were within normal. Carcinomas or other hematological disorders, including autoimmune hemolytic anemia. The management is surgical resection alone. Surgical resection alone is insufficient for normalization of the red blood cells, as was with our patient. We started the patient on steroids and cyclophosphamide. Sometimes ATG and octreotide have been used in conjunction with the thymectomy. The rate of remission is higher with thymectomy and cyclosporin use, as we saw with our patient. Pureate cell aplasia can occur after ABO incompatible stem cell transplantation. This occurs in 77% of ABO incompatible hematological stem cells, hematopoietic stem cell transplants. There's a high frequency of spontaneous resolution with recurrent transfusions. And if anti-donor isohemagglutinin persist for longer than 2 months, then it's unlikely that the patient will spontaneously remit. So 30 to 40% will result in chronic pureate cell aplasia. And then the management for those would be immune suppression, plasma exchange, donor lymphocyte infusions, rituximab, and even IV immunoglobulin. So recombinant human EPO, induced antibody-mediated pureate cell aplasia, has been described actually in patients that are on dialysis or chronic dialysis. These patients, it's seen in patients with renal failure on erythropoietin-stimulating agents. It's more common in the EPREX form, which is an epoetin alpha form, but it was also previously described in other formations, though it's more prevalent in this formation. If you have a patient on hemodialysis or peritoneal dialysis on recombinant EPO who has severe anemia that's not improving, you must consider that this patient could actually have EPO-induced antibody-mediated pureate cell aplasia. The treatment is transfusions to stop all recombinant EPO, and do not switch to an alternative. As I said, the other forms have also previously been implicated. Immunosuppressive therapy can be initiated, and duration of treatment is unknown. So often people will continue treatment until the antibody levels become undetectable, or they discontinue treatment 3 or 4 months after initiation if the patient has no response. They monitor the hemoglobin weekly to assess for transfusion requirements and response to therapy. And they also monitor the reticulocyte count and anti-EPO antibody levels every 1 to 2 weeks during treatment to assess response. Parvovirus B19, as was with Shiny's patient, IV immunoglobulin contains antibodies against parvovirus. It can reverse the pureate cell aplasia, and it should be given at a dose of 2 grams. Some studies say 1 gram, but 2 grams per kg in divided doses over 2 to 4 days. The initial response is about 90%, but relapse is common and can happen in 1 out of 3 patients. Immune reconstitution is imperative, so the patient should be started on ARVs, and immune suppression is not particularly needed in these patients. I got this on up to date on Diamond Blackfan anemia. I won't speak much of it, But just to note that children under the age, under 1 year of age, don't get given steroids, and this is because of growth retardation. And greater than age 1 year, they are given steroids, and usually at higher doses than we give, which is about 2 milligrams per kilogram per day in 1 or 2 divided doses. If there is no improvement with this, hematopoietic stem cell transplant can be considered. Pregnancy-induced purered cell aplasia, it resolves with delivery. Transfusion support is the way to go, and glucocorticoids have been used in some cases. This is a treatment algorithm that is adapted from the ASH review that I spoke about on how I manage acquired purered cell aplasia, where as you can see that with both our patients, we were at this spot particularly where they they were receiving cyclosporin and corticosteroids, and there was a response maintained, and then mine was tapered off. But if there's no response, if the patient has large granular lymphocytic leukemia, alemtuzumab can be used, or ATG. If they've got AMGAS, Velcade or bortezomib can be used. Hypogammaglobulinemia, IV immunoglobulin is the agent of choice. And if it's a B-cell lymphoproliferative, rituximab is of choice. And just to note that there is no point in immunosuppressive therapy without thymectomy in these patients with thymoma. So thymoma, thymectomy, and then immune suppression is best. So if the patient has relapsed refractory purered cell aplasia, other immune suppressive agents outside of the ones that I have mentioned include cyclophosphamide, azathioprine, and sirolimus. Hematopoietic stem cell transplant has been mentioned, but I don't think these patients are often referred for hematopoietic stem cell transplant. In conclusion, purered cell aplasia is a rare hematological disorder with multiple etiologies. It is important to determine underlying or associated pathology due to diagnostic and therapeutic implications that the underlying pathology has. Treatment is diverse and it's dependent on the underlying etiology. I'd like to acknowledge the entire Chris Hani Baragwanath Hospital Hematology Department team, from all our consultants, the fellows, and all of our support staff. I'd also like to acknowledge the NHLS team at Chris Hani Baragwanath Hospital for always assisting us with our diagnostic conundrums, and our patients who trust us even in their most vulnerable times. These are just our references, and we'd like to say Nkosi. Thank you.
Thank you very much, Linda and Shiny, for an excellent overview of purered cell aplasia. I see there are a few questions in the chat box.
While you're
Okay,
looking at the
first-
chat box, Vanita, can I just ask about the first case? It was mentioned in the laboratory workup that the patient was deeply folate deficient, but I may have missed it, but I didn't hear any time after that whether the patient was treated with folate.
Yes, Prof. So the patient was actually put onto folate replacement subsequently, and repeated folate levels had actually normalized. So all those repeat hemoglobins with RPIs that were subsequently low were not in any way attributable to the folate deficiency that he started off with.
Thanks. Back to you, Vanita.
Thanks. And the first question from Jacques is, I'm wondering about the use of immunosuppression in a patient with Parvo B19 associated purered cell aplasia. And the question is, would you give immune suppression, and would you not expect it to worsen the Parvo B19 infection? Linda or Shiny, would you like to answer?
See, Jacques also has his hand up, Vanita. Maybe he wants to clarify.
Yeah, just to say, because I just wanted to clarity on the case, because I was wondering, was there sort of maybe uncertainty initially about the diagnosis of the parvovirus B19, because I mean, immunosuppression will worsen a Parvo B19 BRCA. because that's the mechanism of it, that you've got immunosuppression and the parvovirus persist. So, and I was wondering with, I mean, that's often the challenge with these retrospective reviews of things, that it's not always clear what was the exact cause. There may have been initially uncertainty about the diagnosis, the patient put on immunosuppression, and then later on the diagnosis of Parvo B19, because yeah, I think it's just important that a message don't go out there that immunosuppression is part of the treatment of parvovirus B19 BRCA. And yeah, I was just wondering if this may have contributed to this case trouble in clearing parvovirus. We've seen occasional patients with, and it would be interesting to hear what the others' experiences has been, but we've seen occasional patients with HIV, especially those that don't reconstitute their immune system. We've all seen these HIV patients that's virally suppressed, but after a number of years, they still have a low CD4 count. And we've seen a number of them that they respond to IVIG, but they don't maintain that response. They almost require occasional repeat doses of IVIG to almost maintain them. I'm not sure if anybody else has seen these cases, but generally what our experience have been with parvovirus, if you give an adequate dose of IVIG and you treat the HIV and they immune reconstitute, they don't relapse. And yeah, I mean, this patient, you wouldn't really, the patient had a good CD4 count of 323, so that would be an unusual scenario. Yeah, so I was wondering actually if immunosuppression may not have contributed to this. Maybe the case.
Sorry, Jack, to interrupt you. Can I answer the question? When he'd come to us, he'd already received multiple courses of IV immunoglobulin from the first hospital or the referring hospital. And he had not shown significant sustained response. And I agree with you. In principle, we don't tend to add immune suppression to these patients. We do give them steroids though, because we feel that initially, as we are working up the patient, we don't know enough. The problem with this patient is I think we've already given him 5 to 6 courses of IV immunoglobulin, and he still comes in and relapse. And now he may not be taking his ARVs regularly. He takes them when he's ill, gets much better, and then possibly stops. And I think that has now been clarified towards the end, where he's now lost his virological, he's now in virological failure as well. But maintenance IV immunoglobulin, we haven't used. I don't know if you have any experience about it, Vernon. What about you?
I think the question there would be about cost efficacy versus, yeah, it's a tricky one because IVIG is not cheap, but I've got 2 patients that I know presented with a sort of recurrent, and they tended to keep them a response for about a month to 2 months, or 2 to 3 months, and we gave him a single dose of polygam, sort of just one day, 400 milligram per meter squared, not per meter squared, 400 milligrams per kilogram as a single dose every 2 to 3 months, and he seemed to have done well. But yeah, the other patient that was the plan, but the patient was lost to follow up. So we don't have a lot of patients like that. I mean, it's often, I think the other thing that comes out in your case is there's often competing potential etiological agents. Parvovirus is usually straightforward to diagnose, but often in our patients with HIV, is it the HIV virus itself? Is it the drug? Is it just is it lamivudine or introcitabine? Is it Bactrim? Is it or is it a primary idiopathic or primary immune-mediated PRCA? And it can be quite challenging to sort out. So I think it often happens that a patient is treated with multiple sort of immunosuppression and stopping some of the offending drugs, and it can be very challenging. So I understand that your case was now a bit more tricky because he's had multiple courses and then may have been a bit unclear of what's going on.
Yeah, no, he's been a challenging case and he continues to challenge us. And we've got another patient who seems to be in a very similar position, but we switch between being an aplastic anemia to a pure red cell aplasia. She's always virally suppressed. The CD4 count is also hovering around the 300, but her counts tend to rise and fall, including her platelet count. And what has been interesting for me in these patients with pure red cell aplasia with parvovirus co-infection is I've noticed that the vast majority of them actually have thrombocytosis. I'm not sure if any of you have noticed that, but our patients are sitting with platelet counts of more than 500. And usually when I see them the first time with severe anemia and a high platelet count, I always suspect that there would be parvovirus on board. And that's shown to be true in most instances. Would anybody like to comment on that?
Thanks, Anita. Yeah, I must say I haven't actually noticed that, but we'll certainly, now that you've mentioned it, keep our eyes open. But yeah, happy to hear if any of the other colleagues have similar experiences. But while we wait for anyone else to comment, there's been a question here by Moses Chatambudza as well. If you're giving cyclosporin at a dose of 6 milligram per kilo and your trough level is less than the recommended level, 150 to 200, would you titrate the dose up, even if there's some response to the current dose? Yeah, so I don't know if the speakers want to answer. I just want to maybe say the recommended level would be anything from 150. Some people would go as high as 250. Somewhere between 150 and 250 would be fine. I'll just say that if your patient relapses and after having responded to a previous dose or previous treatment while weaning, then you go back to the initial dose at which you had seen your first response. I take it, Moses, that you're meaning the patient here has got some response. I think the question is always whether this response is the response you're getting up front or the response you're getting at or over time, that you're losing response with weaning. I think if it's an inadequate response where you're not getting transfusion independence and you're not getting a full turnaround, my personal opinion would be to rather get the patient to the recommended trough level and make sure that they are fully immune suppressed in order to stop the T cells from doing their thing. But yeah, happy to hear if there's anybody else that want to comment on that.
No, I mean, I agree with you. We like to increase the dose. Getting trough levels at a hospital is not easy because these are outpatients. So calculating the time when they come in and take their tablets are usually difficult.
Sorry, Virginia.
But patients, we do the trough levels.
Okay. Jacques and then Fatima Faisal.
Yeah, I just want. I think I just wanted to comment with Vanita saying about that. We also find it quite challenging with the cyclosporin trough levels. So it is sometimes quite tricky to adjust, and you may not actually be adjusting to trough levels. So yeah, it's not so straightforward in our setting. I just wanted to sort of give this quickly tell about a case that we had just as a teaching point. A few years ago, I followed up a patient in our clinic who had a thymoma-associated pure red cell aplasia and was then placed on a cyclophosphamide post thymectomy and had a good response, but then for some reason the patient remained on cyclophosphamide. By the time I saw him, he's been on cyclophosphamide, constant sort of low dose. I can't remember, it was 3 or 4 years. So just as a teaching point, cyclophosphamide is mentioned as a treatment option for parietal aplasia, but just for the trainees, know that this is a short-term, you shouldn't really be giving it longer than 6 months due to the risk of secondary myeloid malignancies like AML and myelodysplastic syndrome. So I had a bit of a shock when I followed the patient up and noticed that he's been falling through the cracks and had years of cyclophosphamide. Luckily, he's not developed anything yet, but we keep following him up.
Thanks, Jacques, for that. If there are any other questions, could I just ask one question? How much pregnancy-associated pure rectal aplasia do you all see commonly in your centers? Just put it in the chat box if you don't want to answer.
Vernon, you're muted.
Thanks very much. Thanks, Jacques. Yeah, so you just heard Dr. Jacques Malherbe speaking. For those who don't know him, he's head of hematology at the University of the Free State. And we've got Dr. Fatima Faisal's hand with a hand up from the University of Stellenbosch, consultant hematologist. Fatima.
Thank you, Prof. I just wanted to ask Vanitha, I noticed that you all mentioned the parvovirus PCR. Do you all have the access to the viral loads in any way, or does anyone have access to them, and how does it help? They've recently started doing the viral loads for us at Tygerberg Hospital, and I find that very useful because obviously the level of the viral load would be important instead of just PCR positivity, and that could be useful often determining the etiology and excluding or rather favoring drug causes rather than delayed immune reconstitution.
Can I answer, Fatima? We do not have access to the viral load yet. I know we did ask. We're doing PCRs and IgG, IgM serologies for parvovirus in the peripheral blood. And not sure how useful that is, because in the MED that was shown, although 33% of the patients had viral inclusions on the marrow, both their PCR and IgG, IgM were negative on the peripheral blood. So I personally feel we should be doing PCRs only on the marrow. But yes, I think viral load would be definitely much more useful, and especially in this patient of ours, because we don't seem to be able to get rid of his parvovirus infection at all. It would be nice to know that whether truly it's parvovirus, whether it's HIV associated, whether it was drug induced, whether it's a combination of all. I'd agree with you. That would be the best solution.
I can just maybe comment that our lab has been reporting the viral loads, and interestingly, these ones with a clear, I don't know how you interpret it, and I think our virologist said that currently there's not a lot of data in terms of interpretation, but I remember our patients had these parvovirus viral loads in the billions per microliter or whatever, so I'm not sure how you would interpret it. I suppose if you've got a viral load that high, it does support that that's the primary cause. But I also just wanted to comment on what Vanitha now said regarding the PCR, and we've also seen that, and I think it's important to also realize that there's different serotypes of parvovirus. I can't remember exactly, but the serotypes that we test specifically in South Africa is I think it's serotype 2 and 3, I can't quite remember, but which is the common or the endemic one in Southern Africa, but there's also other serotypes of that is in other parts of the world. And also we've had a few of our cases that had clear morphological features of parvovirus on the bone marrow, antibody negative and PCR negative. And I think those are probably, if I would hazard a guess, cases that are of one of the serotypes that are not common in South Africa. That's what I postulate. So I think it's important just to remember that. But generally, I think if parvovirus is the cause, if you look carefully, you should find morphological features. So that may help.
I think some years ago, now I'm not 100% sure if it was Debbie Yafta that presented a beautiful case of those pathognomonic giant proerythroblasts with a blebbing and so on at one of the research meetings in Bloemfontein. Just about the viral load from my side, I think two things. One, there seems to be some application developing in the blood banking industry. The role of the viral load in PRCA is not well established, and as a matter of fact, I don't think there's any clear value for that yet. I think we should all check with our respective virology laboratories, because it's my understanding that with the PCR assays they use nowadays, that serum is as good as bone marrow. But maybe we are using different assays. I'm not sure. But I'd like to, yeah, I don't know if you've got anybody from the laboratories here that can give a better comment on that than me. But I think the international standard is to use any of a range of fluids, and serum and bone marrow doesn't really matter nowadays, at least. Yeah, so that's all I have on that.
Two more questions from Farah. Does the viral load correspond with the degree of anemia? I have no experience on viral loads. I can't answer that question. And I haven't read anything about it either.
No, not that I'm aware of.
And then from Deborah, there's a question on, can it cause hypocellular marrows? And yes, because Pavo, I think I've understood your question correctly. Pavo can also be a cause of aplastic anemia. So you can get hypocellular marrows where the patient has marrow aplasia, and it does not have to be normal cellular at that time. And thanks, Jack. I will consider maintenance IV immunoglobulins once he's virally suppressed again.
Yeah, no, I think so he probably needs to show that he's compliant. And but I've always wondered about the cost efficacy about, because previously when we got a parvovirus period Aplasia, and they weren't virally suppressed, we first would treat their HIV, get them virally suppressed, and if they don't respond, then give them IVIG. But I'm not sure, depending on how many, I mean, with the risk of transfusions and the cost of transfusion, if that truly is the right thing to do. And I mean, most of our patients, if we give the IVIG, they really respond well. So yeah, I think to answer that question, probably one needs to do a formal health economic assessment, but I'm not so sure that it is the right thing to wait to suppress the viral load, and because it can take some time, and they get multiple transfusions in that time, and then with the cost of blood, you may get, yeah, I mean, it may not be as cost effective.
No, I agree with you. At first presentation, we don't worry about the viral load. We treat them up front with IV immunoglobulins. It's subsequent.
Yeah, I think this patient is a bit more complex, but I was just wondering, maybe like similar to like a common variable immunodeficiency, give him 400 milligrams or 300 to 400 milligrams per kilogram once every 4 to 6 weeks. I don't know. It would be interesting to see. I mean, it's obviously not cheap therapy, but regular transfusion is also not. I mean, he's also got, he's already iron overloaded, so and the cost of iron chelation is definitely going to, I think, probably surpass the treatment of maintenance, if you can call that IVIG. Just a thought.
Well, I will look at it. We'll probably try it out. I mean, we are lost at the moment with it. We need to do something to change things. It's a very good point, and we will think.
And then
we'll
just, sorry, Vinika.
No, go ahead, sorry.
Not at all. Yeah, and so for the trainees, keep in mind to look out for other clinical manifestations of parvovirus. So They often get a skin rash preceding, especially in children. You can have quite dramatic arthralgias. I remember one of the professors in pediatrics when I was a medical student actually telling us about his experience when he was infected with parvovirus from children that he was treating, and he got arthritis like he's never had in his whole life, or arthralgia at the very least. And patients can also present with neurological manifestations, encephalitis, Guillain-Barré, carpal tunnel, all sorts of funny things. So just remember that the clinical symptom spectrum goes a bit broader sometimes. And then I want to say a word or two about Good syndrome. The fact that, you know, things have got eponymous names doesn't mean that they don't exist. I've actually seen 2 cases already, and it's really very useful to, in every patient with a thymoma, to just do immunoglobulin levels, especially if they come past you and if they've got a history of recurrent infections. But recurrent chest infections in a patient with a thymoma is Good syndrome until proven otherwise, and they can be perfectly well treated with preventive intravenous immunoglobulin infusions. So look out for that. If I've seen 2 and we're over 100 people in the room, we were 150 earlier, I'm sure there's going to be hundreds of them out there that we might be missing. So keep your eyes open for those. It's very satisfying to manage them once they're diagnosed. Let me see, our time is, we're almost at the top of the hour. The chat box, Fatima Faisal asks, anyone have experience treating pureed cell aplasia with LGL leukemia? We have 1 patient at the moment. Linda Kuchle, Gotwana, no experience, but the recommendation is alemtuzumab or IVIG. LGL leukemia can be very hard to treat sometimes. That's interesting. I'm trying to remember now. Maybe my colleagues can help me if we've got a patient like that. Can't bring one to mind right away. But nevertheless, that's an interesting comment. Thank you, Fatima. Benita, any final words from you before we close?
I think, I mean, we are seeing about 10 cases of pureed cell aplasia a year. And I think that it's something to consider. I've seen a lot of medical registrars transfusing patients and sending them home and not working them up to see what the actual underlying cause. And my takeaway would be, think about it when you see isolated anemia only, even if the patient's HIV negative, because there are a lot of other causes as well. That would be my take-home message.
Thank you very much, Benita. Yeah, I think we can only agree. Since HIV has come along, my experience is that I'm not sure if we're seeing more HIV, drug-related HIV itself, or parvovirus-induced BRCAs, but they definitely increased greatly in number, and a very important topic for our trainees, for general practice, and of course for the exams. And I think the Borough Wits team have done a wonderful job to pique our interest and to really teach us a lot of things. And thank you also for the lively and great discussion. I think a lot of the value in these deep dives is actually the discussion afterwards, to learn from each other, to see how we in South Africa and some other African countries overcome our challenges. Really, thank you for everyone who's also taken part in the chat box and asked questions. It's fantastic. Jock, is that a new hand or an old hand?
Sorry, I just thought I'll comment on the question on the LGL, so PRCA, and I just quickly looked, and I think I can't remember that we've got experience with this, but my feeling is, and I've just checked on the NCCN guidelines, that you will treat it as you would an LGL normally, probably starting with the standard low-dose methotrexate with or without corticosteroids, second line sort of cyclosporin without steroids. And then if you don't have a response, I think that's where you would probably come in with alemtuzumab. I think probably won't use alemtuzumab frontline due to the due to the really profound immunosuppression that you would expect with that. So that would be my feeling. I don't have personal experience, but I just thought I'll comment on that.
No, I think I would agree, and I want to say don't touch alemtuzumab without your gloves on. It's a great drug in the right place, but it's toxic, and you need to know what you do when you use it. Thanks for that, Jock. Fatima?
Yeah, Prof, I just want to say that some of the literature suggests if it's a chronic LGL that you would perhaps leave it alone if the patient's well and asymptomatic. However, this was an interesting 20-year-old female who presented with a pure red cell aplasia. And just out of interest, she had a parvo PCR that was positive. Anyway, and the viral load was undetectable. So a subsequent PCR was negative, and the marrow showed clear pure red cell aplasia with LGL, underlying LGL. Her other counts were normal, including the neutrophil count, and we used prednisone at 0.5 milligram per kg, and the pure red cell aplasia responded remarkably. We've just repeated her bone marrow, and I saw it today, and she's recovered normal erythropoiesis, but the LGL remains. So the question is, do we treat this or not? But for now, she's stable and transfusion independent on low doses of steroids, 10 milligrams daily. So struggling to wean her off, basically.
Yeah, I think the
but I take all the points, yeah.
I think it's quite clear that LGL that's asymptomatic, you don't treat, because you're never going to get rid of it. It's not a curable. So if they're asymptomatic, you observe them, but you expect a higher rate of relapse, especially if they're only treated with steroids. And that's maybe where the utility of cyclosporin comes in, that you could use that as a steroid sparing agent if you're unable to taper them off the steroids. It may be because you can use that probably longer term with less, not that they don't have side effects, but less side effects. Yeah, just comment on that.
Great. Don't know if Quentin is still around. He's busy writing up a case of TLGL in HIV. Great. I think with that, I'm going to just a few important comments for next week. So next week, very exciting. We've got some Matthew Siftel calls them stars, world-class people from Canada in COVID research. Charlene has opened some discussion this morning on the SACHAS group with questions about management of COVID in the hematology environment these days. Next week, I really want to encourage you not only to come yourselves, but to invite your internal medicine and any other specialty area counterparts to come and join us. Hopefully we've got space for everybody in the room, but please feel free to do that. Our previous COVID session was the best attended one ever, and I think today might have been the second highest. So well done, Benita and the team. You've drawn a crowd, and it was really great. So we appreciate that. The link for CPD points is in the chat. I will just place it right at the bottom again, because I can see that there was so much exciting activity that it's gone up quite high into the discussion. So let me just copy and paste. There you go. So for those who haven't registered for CPD, click on that link, fill in that meeting code that you see there. You're going to need to put that in, and everything else is self-explanatory. So with that, 17:29. We're right on time. Thank you very much, everybody, for keeping to time, for great discussions, and we'll see you all again next week. Bye-bye.
Thank you, and
thank you, Team Blitz. Thank you, everybody. Thanks, Vernon.
Yeah, and a big thank you again to Sistel, Gerdine, and Melanie. Thank you, guys.